Thank you for joining us today. We are celebrating World Arthritis Day on October 12th. Today we have the pleasure of working with Dr. Adam Reinhart. He's a pediatric rheumatologist from Children's Hospital Medical Center and the University of Nebraska Medical Center. He will be presenting today to us to talk about juvenile arthritis. When you finish watching the webinar, please complete the attached survey and ask questions, and we will post the answers to your questions on our website. Take it away, Dr. Reinhart.
Thank you. Well, I think this is a great opportunity for me to touch on some areas of juvenile arthritis therapies and various parts of general health for children with juvenile arthritis that I think can get overlooked or maybe pushed to the side, but are very important for the general health of children. So I hope today to talk with you about the relationship between obesity, cardiovascular health, bone and musculoskeletal health, and then social and emotional well-being, and how they are all interrelated in the child with juvenile arthritis. And I'll start by talking about obesity, which is, in my opinion, one of the most important factors in general health for children, and it is equally, if not more important, to address in the general health for children with juvenile arthritis. We currently are facing an epidemic of obesity in children, and I think that the newest statistics are a bit alarming in that over 15% of school-age children are obese, and greater than 30% are considered overweight. And if you consider that that's healthy school children for the most part, we are seeing even increased percentages of obesity in children with juvenile arthritis. The importance of understanding the impact of obesity is that it significantly impacts long-term health for children, and then secondarily those children when they are adults. It will impact hypercholesterolemia. It increases hypertension risk. It increases the risk for insulin insensitivity, which would be a direct risk for diabetes. There's significant increase in mechanical joint pain for patients who are overweight, and that it adds extra stress on joints, which certainly is something that will impact children who already have inflamed joints due to their underlying arthritis. We see an increased risk of fatty liver, which is important in the fact that we know that many of the medications that individuals are on for arthritis are metabolized through the liver, and a healthy liver is very critical for decreasing the risk for toxicity from those medications. And then I think it's important to recognize that obstructive sleep apnea is something we see in obesity and in children with obesity, and good sleep is a very important general health concept in children. And we know that poor sleep impacts general health. It impacts stress in individuals, and individuals who do not sleep well often are at higher risk for experiencing a greater degree of pain. So these are all factors that are increased in those children who are overweight or meet criteria for obesity. This is just a simple line diagram to kind of reemphasize those relationships. Obesity drives diabetes in adulthood. We see that there's a direct relationship to obesity increasing joint pain. The secondary joint pain then can increase the risk for obesity, as individuals who have joints that hurt often are less likely to be able to exercise efficiently, and therefore their risk for obesity increases. So there's a true cause and effect for both of those entities together. We see obesity will drive cholesterol upward, and then with cholesterol you increase the risk for atherosclerosis. We see that obesity will increase hypertension, which then also increase the risk for atherosclerosis. So obesity as a general health factor is critical in childhood and beyond. So how about obesity and juvenile arthritis? Well, we certainly know obesity is a higher risk in those with physical disabilities, and we would say that juvenile arthritis and inflammation of joints leads to disabilities. We see that certain medications can drive obesity, and the big one that children often deal with inflammatory arthritis is the use of steroids. So certainly steroids are a common medication that will drive up the risk for obesity. And then, interestingly, as more research has been done, we found that obesity itself may be a risk factor for inflammation. We do see that individuals who are chronically overweight or obese will have baseline elevations in their SED rate and CRPs. And these are individuals who do not have an underlying inflammatory illness. They're just overweight but otherwise healthy, and they will have elevated chronic inflammatory markers like a SED rate and CRP. We also see that there are various cytokines that are released with fat, and those cytokines can drive inflammation. These cytokines that can be released with increased fat also will produce inflammatory cytokine production like IL-6 and TNF-alpha, which for many of you, these are the cytokines that some of the medications are targeting to help decrease arthritis. So obesity itself will increase that risk of further driving inflammation and arthritis. So another diagram here, the upper portion just shows the relationship of factors that are commonly experienced in juvenile arthritis and how they drive the obesity. And these are three of the major impacting factors. Inflammation will drive obesity. Obesity itself will drive further inflammation related to the arthritis. The physical disability impacts the obesity risk because of the decreased ability to participate in exercise. And then certainly steroids have a strong influencing role on the risk for obesity. So what is the most effective therapy for obesity and JIA? Well, we really find that despite all of these newer fad diets, if you will, or other different treatment plans that are getting a lot of press on some of the TV shows out there, that there's really been nothing that's been proven to be more effective or safe than simply following a healthy diet and a healthy active lifestyle. In my opinion, these are two of the best treatments you can have your children participate in for arthritis in general, and they have the extra ability to significantly decrease the risk for obesity. So I think these are always your first steps in battling obesity, and that is encouraging a good dietary and active lifestyle plan. Obesity really starts in the family, and there's been well-documented studies to show that obesity is certainly at a greater risk in individuals if parents and siblings are obese. There is new literature out there supporting genetics as being a risk factor for obesity. So certainly we know obesity may run through families and that certain families are at a higher risk for obesity in general. And therefore, I think it's very important for the family to work together to change the entire family's eating habits and exercise habits. It's very difficult to expect or anticipate that a child with arthritis is going to be able to change their dietary habits and their exercise habits if the parents or siblings do not also change. So that we really need to focus on this as being a family directed objective. To look at ways to do this, simply substituting lower fat foods makes a major impact. And a lot of these are common sense, but sometimes they're hard to do, particularly if other family members are being offered the more fatty foods. Children will often gravitate back towards those if they're given as options. So we really encourage taking away all of the fattier food options and really replacing them only with these supplements. And this would be supplementing skim milk for whole milk or 2% milk, changing to low-fat or no-fat yogurts, encouraging certainly fruits and vegetables. And then I think a very important part for the treatment of obesity is limiting fast foods, meals. This is something that I think is becoming increasingly difficult as we're moving to a society where we're always on the run. Our time is pulled in different directions, and there may not be time to pack a meal or to sit down and prepare a meal. So that gets substituted by replacing those meals with fast food choices. I think it's important to remember that desserts are something that should be offered in a selected fashion, and these are quick ways that you can really ruin a good day's worth of meal choices by suddenly having a fatty dessert at dinner or later in the day. So I think substituting dessert choices with things like low-fat ice cream, frozen yogurt, fruits and vegetables fruits, not so much vegetables, are really a good option for families who are targeting obesity. And then I do stress that families are often healthier if they eat together. So sitting down for meals together as a family is a very beneficial way to reinforce healthy eating activities. It's a way to provide good feedback for the patient, but also for the rest of the family members that they are doing a good job with their dietary plan. And I think eating together as a family is an opportunity for the family to discuss how overall the patient's juvenile arthritis is affecting their day-to-day activities at school, in their social life. And so there's that added benefit of sitting together and eating together majority of the meals per week if possible. We do see that friends significantly impact obesity risk, and friends are often selected because they're similar to each other. So certainly we see that fast food choices often make cluster amongst friends. We see that certainly individuals who have friends that frequently eat out are more likely to make poor nutrition choices. It's really difficult for a child with juvenile arthritis to choose to eat a healthy meal when all of their friends are sitting down to eat a hamburger and fries. It's often a little bit intimidating to make that choice. Sometimes there may be some peer pressure to not choose the healthier choice option. So having friends understand the need for a healthy diet for a child with juvenile arthritis is very useful. We definitely see that sports and exercise choices are heavily influenced by friends. We know that an individual is more likely to participate in an exercise activity if they also have friends that are participating in those activities. And we're seeing more and more trends for individuals to spend a lot of time in front of TVs and computers, gaming, and some friends can now sit at their individual homes and for hours game online. This is a big risk in the fact that not only does it decrease their activity levels, but certainly I think food choices are impacted by sitting in front of the computer for hours at end. It's much easier to snack on an easily accessible food like chips than it is to prepare a healthy meal during those prolonged gaming sessions. So we would certainly recommend participation if screen activities are enjoyed by friends to do active screen activities. Things like Wii Fit or Xbox Connect or others are very useful activity-engaging exercises for friends. We do know that adolescents may underestimate their degree of obesity or overweight if they're surrounded by other peers who are overweight and obese. And then we really are becoming more and more concerned that overweight youth are often socially isolated. They're certainly at a greater risk for bullying, and so these are all reasons to generally focus on obesity as an important part of juvenile arthritis treatment and the treatment of pediatric children in general. Well, school can certainly impact obesity. It's very strongly recommended that children participate in organized sports. This is something that should be done if the children are enjoying those sports. I don't believe children should be forced to do a sport if they don't enjoy it, but I think that children should be allowed to pick sports that they want to try and encouraged to participate whenever possible. Activity programs are often provided by schools outside of the school day. These can be outside of organized sports, but it can be equally beneficial for those children who don't want to necessarily participate in a team sport, but want to participate in activities with other peers. It is critical that physical education class be an option for children with juvenile arthritis. This is something that can strongly influence the risk for obesity. There's additional education often as to the importance of obesity risk and health in physical education classes. At the same time, the school should provide nutritional education for children. I think it behooves parents to also know what the school is offering their kids as far as meal choices. It's still alarming in some cases, some of the choices that children are given at school, and it's easy for a child when they are not being monitored to make poor choices. If there's some individuals at school that can help the parents monitor while the children at school as to what food choices are being made, that's useful. And then school physical therapy is very important. It's certainly something that should be provided at most schools, and it's an additional benefit for children with arthritis. Cardiovascular health is the next important topic. It's something that I think can be forgotten as being an important part of pediatric health. It's maybe something that's considered as a risk more so to adults or the elderly. And this is just another diagram that really points out that obesity does also drive the risk for cardiovascular disease. The atherosclerosis, which is the formation of plaques within arteries, is driven by increased cholesterol and increased hypertension, which are both increased by obesity. We certainly see atherosclerosis at a high risk in patients who have diabetes, which can also be impacted by obesity. When you look at cardiovascular health, atherosclerosis does begin in childhood, and it's at a greater risk in children who have chronic inflammation. And the reason for this is that atherosclerosis not only is driven by obesity, but it's driven by patients who are inactive. It's driven by patients who have increased general stress. And then it's also increased by those other choices that people make, such as poor foods with high cholesterol, elevated blood pressures. Over time, atherosclerosis leads to increased risk for a myocardial infarction or heart attacks. There's an increased link to stroke risk and peripheral vascular disease with atherosclerosis. And when we talk about juvenile arthritis, specifically, there's a strong influence of chronic inflammation on atherosclerosis. And this is because much like fat, we can see increased production of inflammatory cytokines that drive inflammation. Atherosclerosis itself is basically an inflammatory injury to the blood vessel walls. So cytokines that are released during chronic inflammation or chronic inflammatory conditions, such as juvenile arthritis, those can drive increased atherosclerotic lesions to form. And these are the cytokines that also drive the inflammation in joints, such as interleukin-1, TNF-alpha, among others. As with individuals who are overweight or obese, we see some chronic elevated inflammatory markers in patients who have smoldering inflammation. With smoldering inflammation, we can see increased cardiovascular risk even when patients are clinically feeling well. So patients who have chronic CRP elevations or chronic sedimentation rate elevations are still at risk for atherosclerosis progressing, even if they do not seem to have a lot of symptoms from their inflammatory condition at the time. So really treating patients until they do not have any evidence of inflammation systemically is the key, not just treating to the point of feeling better or improved. So again, the inflammation drives atherosclerosis and it drives obesity. And I think you'll begin to see that there's a strong relationship for all of these components that work together to impact your children's health. So how do you treat cardiovascular disease and juvenile arthritis? Well, the number one aspect of treatment is exercise. And then another important aspect is controlling the inflammation, as we just spoke about. If you limit the amount of chronic inflammation that's driving the juvenile arthritis, you secondarily will decrease the risk for atherosclerosis. Dietary choices are important to lower cholesterol levels. These dietary choices will include fruits and vegetables. Green leafy vegetables are filled with antioxidants. Vitamin C-rich fruits and vegetables will aid in cardiovascular health. And then some individuals will benefit from multivitamins that contain antioxidants. Vitamin E, B6, or folate can also help with some cardiovascular risk factors. Certainly, as individuals with juvenile arthritis move in their teenage years, there needs to be a strong discussion about avoidance of smoking. Smoking is a very strong predictor of atherosclerosis and cardiovascular risk. And then I think sometimes lost in the general discussion is stress reduction. We must work to limit stress. Chronic stress is a risk factor for cardiovascular health. And then blood pressure control. We do know that some of the medications, particularly steroids, will drive up blood pressures in patients with juvenile arthritis. So this is just a diagram that shows how exercise can impact atherosclerosis. Exercise will decrease obesity. It will decrease stress. We certainly know that exercise will help drive down blood pressures, and then it will drive down bad cholesterol. So exercise, in addition to controlling inflammation, can dramatically decrease cardiovascular atherosclerosis risk in patients with juvenile arthritis. Bone health and growth are critical factors for health in children, but even more critical in patients with juvenile arthritis. We know that the greatest degree of bone density is placed in teenage years for females ages rapidly increase. Once females turn postmenopausal, we see a dramatic decrease even further for bone density. So children in their teenage years are really packing on the density that they will rely upon for the rest of their life. Growth certainly is impacted by chronic inflammation, and we know that growth starts to slow or stop in the mid to late teens for females and late teens, early 20s for males. Any impact on growth during the teenage years will decrease the overall growth velocity and may lead to patients not reaching their full growth potential. We see that there are really three major ways to impact bone health and bone growth in general pediatrics, one of which I think is under-recognized. Muscle mass has a direct relationship to bone density. The more muscle an individual has, the more likely they're to have better bone density. Certainly nutrition is critical. There must be adequate calcium and vitamin D to provide the minerals that will build the bones in individuals. And then secondarily, there must be healthy, adequate protein intake to build lean body mass, muscular mass that again will increase bone density. And exercise, weight-bearing types activities will help provide stress to bones and help build the bone density in individuals. Well, how is bone health and growth impacted by juvenile arthritis? Well, in some studies, about 2 times the likelihood of decreased bone density in juvenile arthritis compared to their peers. We see that there's over 40% of teenagers with juvenile arthritis in some studies have lower bone density than would be expected. We do see that the subsets of juvenile arthritis that have more systemic inflammation are more likely to produce lower bone densities, and so these would be your individuals who have polyarticular juvenile arthritis or systemic juvenile idiopathic arthritis, but there's still a risk factor for patients who have oligoarthritis. There's increased risk of short stature and low weight in some individuals, particularly systemic arthritis patients or patients with bad polyarthritis, and that's because chronic inflammation will require some of the energy that should be used to aid in growth for children, instead to be diverted to help combat the chronic inflammation. So chronic inflammation itself can lead to short stature, low weight, and low muscle mass. Again, we just talked about the influence of chronic inflammation on bone density and growth. We see that there's that direct linear relationship to muscle strength and mass. Locally, you can have decreased muscle mass related to not using a specific joint because of arthritis. That joint will then lead to surrounding muscle groups to atrophy. When those muscle groups atrophy, there will be localized decreased bone density in those areas. So not only can you have diffuse decrease in bone density, but you can also have localized decrease in bone density specific to areas where there is ongoing chronic arthritis. Delayed puberty can be influenced by chronic inflammation. We see that patients who have chronic inflammatory conditions may decrease or delay their puberty onset, and this could decrease their overall growth because of the delayed puberty. We see that there is also increased energy requirements for patients who have chronic inflammation, and again, that can take away the calories and nutrition that is needed to build bones and muscles and divert those to combat the chronic inflammation instead. And we see lower insulin-like growth factors in individuals who have chronic inflammation. Insulin-like growth factor is a strong predictor of growth in childhood. So again, inflammation, inactivity, and steroids all negatively impact bone density, while muscle mass, adequate calcium and vitamin D intake positively improve bone density. If you over time have prolonged increasing issues with decreased bone density, you will end up having increased risk for osteoporosis and increased risk for fracture. Fracture risk certainly is increased in juvenile arthritis, and we seem to again see that this risk is greater in those patients who have more systemic inflammation, those with polyarticular disease or systemic disease that's influenced by not only their persistent inflammation, but these individuals are also more likely to have been exposed to chronic steroid use, which is a separate indicator of risk for fractures in patients with juvenile arthritis. And then the longer that an individual has inflammation and arthritis, the more likely they're to develop fractures. So these are strong risk factors for fractures in the long run in juvenile arthritis. Well, how do you treat juvenile arthritis and improve bone health? Certainly we see physical therapy as critical. You must be able to move joints so that way you can participate in strengthening exercises or resistance training that will increase muscle mass and bone density. So the first part of any treatment program is to treat the arthritis and improve range of motion of joints that are limiting individuals. Then they can secondarily start to begin to do weight-bearing activities, and ideally more vigorous weight-bearing activities are important. Non-weight-bearing activities are good for cardiovascular health and obesity risk, but they do not seem to significantly improve bone density. So although swimming and long-distance running can help with general health in children, we want to see children also participate in activities that will cause some more heavy impact to their bones that then builds the bone density. We need to see strength training, and this is where the muscle mass comes in. The more muscle you have, the better bone density you will secure. You want to have your children and patients with juvenile arthritis control their arthritis as quickly as possible to prevent the risk factors for chronic inflammatory driven bone density influence. And then we see that steroid-sparing agents need to be used, particularly because steroids very strongly impact bone density. The longer a patient is on steroids and the higher the dose of steroids, the more dramatic their bone density issues become. Therefore, it is important to use steroid-sparing agents to try to limit the amount and duration of steroid use in children. Dietary impact, again, these can be made with good healthy choices at home. Dairy is important for calcium. We also see that tuna and salmon can not only improve good quality protein, but also have a good vitamin D source. Collard greens and green leafy vegetables often have good calcium. And then we see that potatoes, raisins, and those green leafy vegetables, along with tomato products, have a good rich vitamin D source. Fortunately, now we do see that there are many foods that are fortified with calcium and vitamin D, such as breakfast cereals, breads, milk. And so these are other options that can be provided to increase the calcium and vitamin D access that your children have. We know that in some individuals with juvenile arthritis, they can have deficiencies in calcium and vitamin D, but it really has not been shown that prophylactically supplementing calcium and vitamin D in all children with juvenile arthritis impacts their bone density. Good healthy diet and exercise are probably more important, and then it's more likely recommended that additional supplementation with calcium and vitamin D be given to those who have chronic requirements for steroids or have a known deficiency of vitamin D on testing, or a known calcium deficiency, or they already have been diagnosed with low bone density such as osteopenia or osteoporosis on things like a DEXA scan. I'll close this talk in emphasizing the importance of exercise. I think you've probably seen that exercise impacts all of those topics we discussed previously. It heavily influences obesity, cardiovascular health, and bone health. This, again, just reemphasizes that we see that exercise will decrease hypertension, exercise decreases stress, exercise decreases cholesterol. These are all things that decrease atherosclerosis. We see exercise dramatically decrease obesity, which secondarily impacts your atherosclerosis and diabetes risk. We see that exercise itself will improve bone density. Exercise also will increase muscle mass that will increase bone density. So really, it's rare to have one treatment option impacts so many areas, but we do know for sure that exercise really is a critical part for health in all children, but particularly in those with juvenile arthritis. And it should really be a lifelong treatment option. Exercise in children and adolescents is something that we're finding is becoming more and more deficient. In 2008, there were some official guidelines made for children aged 6 to 17. The recommendation was that 60 minutes of moderate to vigorous exercise be performed daily in all children aged 6 to 17. Within that 60 minutes per day, there should be 3 days a week where a bone and muscle strengthening exercise is done. Stretching and flexibility activities are equally important and should be included in those 60 minutes. We want to encourage patients to participate not only in cardiovascular exercise, but also flexibility and muscle strength training, which will impact the overall health of their juvenile arthritis. We know that even healthy teenagers, only about 40 to 45% of teenagers are meeting this goal, and those are healthy individuals. So certainly they're not individuals impacted by chronic inflammation and chronic arthritis. So you can certainly extrapolate that far less patients with juvenile arthritis are meeting these goals. And it's important to remember that children establish their activity patterns that they carry over into adulthood. So if children are not active as in their early years or adolescence, it's very unlikely they're going to be successfully active as adults. Therefore, their risk for things like atherosclerosis, obesity, and diabetes exponentially increase as adults if they did not establish good exercise habits as children. So what are some moderate to vigorous exercises that are being recommended? Well, cycling is a moderate to vigorous exercise, jump roping, running, martial arts, sports such as soccer, swimming, tennis, basketball, and cross country are all moderate to vigorous exercises. Bone strengthening exercises or exercises that include running and jumping, those impact type activities. Jumping rope really is a very common and very good exercise for individuals, particularly pediatric patients. It's why they often include jump roping in many physical education classes and courses. Again, we want to have the impact activities that build muscle strength, and these would be activities such as basketball, gymnastics, volleyball, and tennis. Resistance training has added benefits in that it will recruit more nerves to innervate those muscles that you're building when you exercise. Resistance training improves general body awareness by improving those neuronal connections with muscle groups. Certainly, we see patients who have a good resistance training program have increased coordination. This secondarily increases their endurance. Stronger muscles lead to the ability for patients to participate in prolonged endurance activities. Things that will provide resistance training are elastic or resistant bands, free weights or machine weights, plyometrics, sit-ups and push-ups, tug-of-war, or jumping rope. Stretching and flexibility is critical, particularly in patients who have arthritis. It's recommended that stretching and flexibility activities be done at least 2 to 3 days per week. This is probably for healthy individuals, and it would be recommended that they be done really daily for patients with active or chronic arthritis. The goal is to stretch until you have a sensation of tightness, but not discomfort. You want to have a child or a patient with juvenile arthritis hold a stretch for 30 seconds per stretch, shooting for about 60 seconds per muscle group. Physical therapy is important for directing specific stretching and range of motion activities for patients who have specific areas of decreased range of motion. And then coaches and athletic trainers can be very valuable in providing stretching activities based on the current sport age child or a individual is participating in. And these are stretching exercises that will focus on muscle groups that are more likely to be injured or joints that are more likely to be strained during a particular sporting activity or event. Goals of exercise in juvenile arthritis. When the disease is active, the goal is to maintain. The goal is to maintain range of motion, to maintain muscle strength and mass, and to maintain functional capacity. However, when the disease is well controlled, the goal is then to make gains, to improve aerobic capacity, improve exercise tolerance, to improve muscular fitness and mass, and to encourage patients to and families to have their kids participate in age-appropriate physical activities. So maintain when the disease is active, but make gains and really not limit children when their disease is well controlled. What are the benefits? Well, these are really just reiterating many of the topics we've already discussed. Exercise maintains healthy body weight. It improves bone density. It improves bone mass. There's improved motor development in kids who are more active. The younger children are encouraged to become active, the more likely that they become more able to participate in their gross motor skills. They show better development in that aspect. Secondarily, we see that these individuals often have better cognition. Individuals who exercise seem to focus better. They seem to do better with school. Their active performance goes up. We see that exercise has a direct impact on decreasing pain. We know that for many conditions like adults with fibromyalgia or children with amplified pain, that exercise is one of the most important features of decreasing pain in those individuals. We see that exercise decreases fatigue, and this is largely impacted by the fact that patients and kids with juvenile arthritis who exercise sleep better. With improved sleep, there's decreased fatigue, there's increased focus at school, and secondarily, there's decreased stress. Improvement in immune function is seen in patients who are healthy and exercise regularly. Individuals who exercise regularly seem to be less likely to become ill and sick with common colds, or if they do get common colds, they often are less impacted by them. And then exercise encourages participation with peers. This increases social interactions and the development of social skills. Exercise barriers in juvenile arthritis. Well, certainly when joints are limited or joints have decreased range of motion or some pain with range of motion, general mobility decreases, so exercise is more difficult. There's often some anxiety over the worry for will my joints be damaged if I participate in activities when I have arthritis. When arthritis is active, it often excludes individuals from participating with their peers in group activities. This secondarily can decrease a sense of self-esteem and well-being. The secondary impact of juvenile arthritis leading to shorter stature, being overweight, and just simply being behind in their physical abilities compared to their peers leads to decreased self-esteem. And there's certainly an impact by the amount of time and expense that children with juvenile arthritis have to devote to exercise and physical therapy. This goes beyond those 60 minutes a day that are recommended for healthy individuals. Children with arthritis need additional conditioning. They need additional focused therapy. And so these can add up and become a little bit of a barrier to being able to reach full exercise capacity in children. Factors that influence compliance with exercise, certainly those individuals who have more joints involved or more systemic inflammation decreases their likelihood to be able to participate in exercise regularly. Larger joints involvement is an impact. Certainly individuals who have hip involvement or shoulder involvement have more difficulty participating in regular exercise. The longer individuals have disease, the more likely they are to have poor exercise compliance. And then very early onset of disease as a young child impacts exercise compliance because they often limit their activities from a very early age, and those deficits are compounded every year. What are some outcomes of decreased exercise compliance in juvenile arthritis? Well, in the short term, there's further functional deterioration. We know that children with arthritis who don't exercise experience further loss of range of motion. They have increased stiffness scores. They have secondary increased loss in general strength. And what's unfortunate is these losses don't resolve in many cases even when the disease does finally reach a remission. So they often don't get all of those gains back. They may never reach their baseline again. In the long term, we've talked about those risks. There's increased risk for cardiovascular disease, osteoporosis, and diabetes. We certainly see that patients who have been impacted by arthritis, if they don't exercise and maintain their aerobic capacity and exercise capacity, they may have to limit their career choices because they can't do the types of activities that other people are able to do who don't have the same limitations. There was one study that found that children who had arthritis when they were adults had a limited exercise capacity of about 20 years compared to their peers. So patients who were 50 were functioning more as 70-year-olds in their exercise tolerance. Patients who were 30 were functioning more like 50-year-olds who had exercise tolerance. This isn't every case, but that's a very dramatic impact in long-term health and happiness. So these are some easy exercise recommendations. Physical activity is safe and is encouraged even during times of disease activities. It just may need to be modified during those activities. But patients should be allowed to participate in low-impact activities to the degree where there's some soreness but not pain. And a degree of soreness is not a reason to stop the activity. So we know that soreness is a sign that muscle groups and tendons and bones are being impacted by exercise. We all know that if we do any type of new exercise, we're going to be a bit sore, and that's okay. So you should encourage activities to a point of soreness, but not pain. And I can't emphasize enough the importance of home exercise programs. These are things that benefit children in a great way because they can be done daily, whereas often physical therapy or monitored exercise programs are limited to a few days per week. It really decreases the expense and time commitment of going to hospitals or clinics or outpatient treatment-based areas. We see that home exercise plans often improve the health from a family standpoint. Children of active patients or active parents are more likely to be active from an early age and lifelong. And then home exercise plans can often limit the amount of inactive screen time and find ways to improve screen time for children. So anytime a child wants screen time, that should be a time that there is also an associated exercise that is done to allow them to have further screen time, whether that's making the screen time an activity where they're active while they watch TV. I think it's very easy to recommend that children who are in front of their TV do their stretching exercise, do range of motion exercises. They can often do strength exercises. So I think screen time should be limited, but if the screen time is allowed for children, then that screen time should be taken advantage of, and they should be encouraged to find ways to exercise during that screen time as much as possible. Well, children who go to school should be encouraged to walk or ride bikes to school. It's certainly been found that those are the types of individuals that are more likely to meet that 1 hour of daily recommended exercise. Physical education classes, again, must be encouraged. It's okay to modify or self-limit activities, but children with juvenile arthritis should not be allowed to not participate in PE classes or gym class. This is really a detriment to their health if they're taken out of physical education class rather than a benefit. Well, what activities should be done during active disease? Well, these are more range of motion. Remember, we're looking to maintain. So you want to do range of motion activities, particularly for those joints that are impacted by a current flare of arthritis. Aquatic therapies, swimming can be useful because of the removal of the weight-bearing impact type discomfort that can occur during active disease. Cycling or walking can replace high-impact activities, and then doing isometric resistance muscle contractions multiple times per day can help maintain muscle strength while avoiding high-impact contact activities, which would be contraindicated during times of highly active disease. For those who have chronic disease but not overly active and not in an acute flare, you still want to focus on range of motion activities. Things like yoga and Tai Chi are great. And then encouraging lower impact activities such as walking, swimming, water aerobics, low impact dance, and jump rope. And then light resistance training, higher reps, lower weights will be useful to maintain strength. When there are periods of inactive disease, this is when you need to focus on making gains. And so really adopting the recommendations for a healthy child is encouraged. So trying to find 60 minutes of the day of moderate to vigorous exercise in addition to continuing range of motion activities and resistance training. So biking, swimming, running, martial arts, jump rope, games involving running or chasing like tag, and then organized sports such as soccer, tennis, and basketball, along with swimming, are encouraged. Resistance training can now add increased weight with lower reps, 6 to 10 reps, and this will help build muscle mass. You have to add weight to build mass. So when disease is active, you want lower weights, higher repetition to maintain, but when active disease activity is well controlled, then you can add weight to build muscle mass. So that ends my discussion today. I look forward to any additional questions, and I wanted to thank the Arthritis Foundation for this opportunity to speak to you about some very important health topics.
All right. Thank you, Dr. Reinhardt, and thank you, everyone, for viewing this webcast. If viewing prior to October 12th, when you complete the post follow-up survey, you will be able to ask Dr. Reinhardt follow-up questions, and we will post the questions and the answers on our website. Thank you again.